In regards to the suite of cardiometabolic disorders, including diabetes, dyslipidemias, and hypertension, can you define the therapeutic goals for that suite relative to cardiovascular health and preventing CVD, ACS, and stroke?
I think most of us are pretty clear what we want to do about the risk factors that are part of the cardiometabolic syndrome, that whole group of abnormalities. When it comes to the diabetes, we like to treat it so that the hemoglobin A1C finishes up at less than 7. And most people agree that that is an appropriate target. Then we have the blood pressure issue. And that's interesting because for most hypertension, people say get the blood pressure to less than 140/90. But until recently, they said, if someone's got diabetes, we'd like you to be a bit more aggressive and get the pressure down to less than 130/80. But now the American Diabetes Association has come back and said, no, 140/90 is probably good enough. Let's not overdo it because there might be some risks with over-treating the blood pressure. With the lipids, though, I think most of us agree we'd like to see an LDL cholesterol nicely below 100, if possible below 70. Some people even like to shoot for 60. So with the diabetes well managed, with the blood pressure well managed, with the lipids well managed, we're really off to a terrific start. And there's nice evidence that if you deal with all three of those big issues at the same time, you really do have a significant benefit in terms of preventing major cardiovascular events, heart attacks, strokes, heart failure, and the like.
What about disparities in expectations and therapeutic goals between patients and providers?
There has always been something of a disconnect between what doctors know, what doctors do, what patients know, and what patients do. And they've even coined the term clinical inertia to describe the fact that doctors know everything we've been talking about. Yes, you want your A1C to be less than 7. Yes, you want your blood pressure to be less than 140/90. Yes, you want your LDL cholesterol to be at a certain level. Very often, doctors don't achieve that, at least not completely, in their patients. And it's not clear why doctors sometimes stop and say, I've done enough. Maybe they have a fear of over-prescribing, over-medicating. And patients, by the same token, also are often very resistant. You can explain to them, yes, I want your pressure down, I want your lipids down, I want your cholesterol down, I want your sugar down, and they'll go along with it. But as you start to get a little more aggressive with treatment, there's almost this, doctor, haven't we done enough? You have to work out the best compromise you can most of the time, because I think now so many people are aware of the importance of treating diabetes and hypertension and lipid disorders. They know how important that is. It's getting easier to get good results. We try to diagnose cardiovascular risk factors, diabetes, lipid disorders, blood pressure, as early as possible, out of belief that the sooner we get to work and get these issues controlled, the more likely it is that the patient will have a long period without any major sort of cardiovascular bad outcome. Doesn't always work that way, of course. And it's amazing how we sometimes will get a patient who has somehow managed to dodge doctors, dodge organized healthcare, and appears with dreadful blood pressure, lipids totally out of control, quite severe diabetes, and we have to start from this very difficult situation. But you know what? It's worth it. And once you get those factors under control, then you can start to have some confidence that you're going to make a big difference for a patient. In other words, it's never too late. Obviously, we like to start as soon as possible, but it's never too late.